antegrade guiding catheter, then you are very lucky. But most often doesn't happen in a real complex CTO of good duration. It doesn't happen. So then you have to go for the reverse cut, get prepared for it. It's simply that the antegrade wire and the retrograde wire in the CTO segment and put a smaller balloon in the first 2 millimeter, if possible higher grade, depending on the IVAS findings, I do sizing the balloon. Initial 2 millimeter balloons with the overlap of the wires can be done. If they're in the common space, you can pass the retrograde wire into the guiding catheter. This is a simple way of doing a reverse cut. So there are many types of reverse cut. Once it's a simple reverse cut, what I told. Sometimes in the distal segment of the CTO, we keep a low profile balloon, 2 millimeter balloon, and the antegrade wire, which is in the subintima. And the retrograde wire is Gaia wires are very good. Because of the one-to-one torque, you can manipulate. And when the balloon is deflating, you puncture that part. This is a contemporary reverse cut. And the directed reverse cut is beyond the CTO segment. It's a difficult one. Beyond the CTO segment, doing the reverse cut. So then we have to use the IVAS. That's what I told. IVAS usage in reverse cut is very, very important. If it's straightforward case, I don't use. But it's a case where the difficulty is in reverse cut, I use IVAS. It guides us. How it guides us is like this. If the both wires in the antegrade in the subintimal space, it's the most easier thing. You're lucky. But in the retrograde wire is the intima and the antegrade is subintima. This is the most difficult challenge. So IVAS guides you regarding the position of the wires. IVAS guides you how much size of the balloon you can use. This is very important. Next step is the externalization. You see, once the wire goes to the near to the beyond the proximal cap, how to externalize the wire? Because the wire should be able to manipulate through the curve. Sometimes we have to de-escalate the wire. Suppose you use a Gayatri wire to cross the segment. Then the Gayatri, if you try in the RCA band, proximal band, it will perforate. That will cause extravasation, dissection. So I have to de-escalate wire to a softer wire like a cyan black or Fielder XT, something like that. Then another important thing is once the wire goes into the antegrade guiding, it's very easy. But many times it doesn't go. So what we have to do after doing a reverse cut also. So sometimes reverse cut fails also. Then we have to use a guideline or Gadgilla, whatever available. So get the wire into the extension catheter. That is more easy. Why it protects? It protects the ostium of the, like left main you are doing externalization. The guide extension, you put it to the middle lady, then the left main is protected. That's important. And easy to externalize also. So guideliner usage is more these days for externalization. Then the snaring of the wire has come down in my practice once I start using the guideliner. So this is a simple wire cross. You are very lucky, but it's a guideliner or stent assisted. Sometimes the antegrade proximal near to beyond the ostium, like RCA C2 is there, I stent the proximal part beyond the bend. So this is called stent assisted. We can use a stent assist also to use the externalization. And the wire of choice is the RG3. I skipped that one. Is a long 330. You should have a Fielder FC also very useful. Hydrophilic 300 centimeters wire is very important. They are all flimsy wires. You have to be careful. So once the wire enters the guiding catheter, you have to trap the wire with a balloon support. Because the guiding catheter retrograde has to enter the antegrade guide, you need the balloon trap. After that, change to RG3 wire and externalize that wire through the groin. How to do that, you know, most of the people I think experienced. Detach the Y connector from the guiding catheter, put your introducer needle, get the wire into that. But see that the loop is not stretched. That is very important. Inside the loop is not stretched. You have to maintain the distance both sides. And after that you can do the wiring and all. So sometimes we fail. This technique I have done in many cases. This is Renduva technique. Sometimes externalization is very difficult. You can pass one wire into the other both micro catheters in the guiding catheter. You can exchange that. Even you can exchange one wire into the, like this I have done here. This is over. Last slide. So these wires of passing one wire in the C2O segment by manipulation, usually guide to is very good within the C2O segment. We can pass into the antegrade microcatheter and finish the technique. The acceleration steps can be minimized. So this is snare pull. Sometimes we do E snare and Amplus snare can be used. The more spacious part, cephalic trunk area, that area is the ideal to take all these maneuvers. Very important. So with it all of equipment is important. Check for collateral injury always after finishing. And channel injury if happens, you can seal with coils as I told. So this is the end. This is the final results like this. And I think complication rate is there. Perforation is the main risk, collateral injury. I invite you all for the 10th live summit in IJC2O in Western Hyderabad, 7th, 8th, 9th June. All are welcome for this great meeting. Thank you.
Very good lecture, sir. I think we are running short of time. Can we move to...
Yes, we'll move to Dhaka.
Yeah.
Dr. Fazila.
On. Yeah. Right. So we've done our post-dilatation, and what we did is...
Your screen is not visible.
The screen is... Okay, right. So we did our post-dilatation, and we also actually, just to make the left main really properly, the stents properly opposed, no malopposition, what we did is actually, we did a case there as well. We opened up the strut of the L6, did a case, and then did a report. And in the final result, you can see that there is no stent malopposition now. The struts are very well open, and
but Fazila, just after the 10, you can see it's a big problem there in the proximal LAD. Can you see it? 10?
Yes, exactly. So what we were planning about that particular part of the LAD, we are planning to take a 6 millimeter, very small NC balloon at that LAD point and go up to very high pressures. So overall, the left main, there is no under expansion or malopposition. The struts are fine. The edge of the LAD is also fine. That particular point, we have also noticed it, and our aim is to take a small 6 millimeter NC balloon and do a good, thorough job of post-dilatation at that site of the LAD. But apart from them, can we have a look at the angiographic view, please? The final angiographic view is like this. Can we go to the epicranial, please?
Dr. Fazila, would you think of taking an OPNNC balloon at that point?
Yeah, we can do that as well. But angiographically, things look great, right? Obviously but there's a bit of a narrowing there also angiographically. But what we will do is we'll take a OPN or any balloon that can go up to very high pressure and do our final there. And because in the OCT we did notice that thing in the LAD, yes.
Dr. Fazila, angiographically it looks beautiful, but it's just that we have imaging and we are seeing that, so we were just wondering if we could
work on that. Yes, we'll work on that off screen. But so that's us from Dhaka, and thank you so much for having us over.
Thank you, Dr. Fazila. That's a great case, a very learning case. You handled it very beautifully, and with all the proper steps which were followed, and a great end result. Thank you so much.
Thank you. Thank you.
We'll go to our next live inbox case by Dr. Sujata Vipadla.
Presentation. I would stop and think. Good morning. Greetings from Indus Hospitals to WCC 2024. Today we have a 54-year-old male patient. He's a hypertensive, non-diabetic, and he presented to us with history of angina class 2. He had an ischemic stroke about a month back. The carotid Doppler has shown right internal carotid artery occlusion and there were infarcts in the MRI scan. So I'll show you the ECG. Echo showed severe concentric LVH and wall motion in the LAD territory, and the ejection fraction was 0.35. And the creatinine clearance is about 55 ml per minute. The next slide, this is the ECG. So you can see that there is a very good size circumflex, and the LAD there is ostial occlusion. You can see that there is some antegrade filling, and there is some ostial disease of the circumflex. There's less than 50% stenosis. You can see that the ostium of the LAD is occluded. Then the right coronary, there are plaques and there's no significant stenosis, and we can see that there is a retrograde filling of the RCA, of the LAD. Next. So here you can see clearly that it's a short occlusion. So with this history and this angiogram, what should we do is the next question. Next slide. So we did further evaluation of this patient. We did his BCIS Jeopardy score, which was 8. The maximum score is 12. And we also decided to do a viability study, and we found that all the territories of LAD and all segments of the myocardium are viable with perfusion defects in the LAD territory. Can you show the next slide? So you can see that there are perfusion defects in the anterior and apical segments, but these segments have taken up the FDG and were reported as viable. Next slide. So with this information, what is the strategy? Should we revascularize at all? Considering the BCIS, revived BCIS 2 trial, should we revascularize? So, should we revascularize at all? That is the first question.
Yeah, I agree with you that recent BCSI, revived BCS trial shows that if you revascularize the totally occluded artery in a stable patient, there is no, but here the large area of myocardium is jeopardized. So, and the patient is having a class 3 angina. So, I can't leave the patient alone without, only on medical management. That is my strategy.
How many of you would go for a medical management? Can you raise your hand, please? Only medical management for this patient. A guideline-directed medical management.
No. Sir, nobody believes your trial. Revived BCIS trial, why nobody is believing it? Dr. Mamas is here and is very unhappy.
What was the LV function? What's the LV function?
35.
I mean, if it's for symptoms, though, I mean, so BCIS Revived showed no difference in mortality or heart failure admissions, and so revascularizing this won't change mortality or heart failure or readmissions, but it may impact on symptoms. So I would do this purely from a symptomatic perspective with no expectation that you're going to change prognosis.
Class 2 symptoms, but sir, though I did an intervention, I could argue that at 2 years, the symptoms did catch up. I mean, there was not much difference between medical and so the reason why I want to do this patient is because he's 20